All right. Once again, good morning, everybody. Thank you for dialing into our Ask the Doc Women's Health Awareness. All lines will be muted for the remainder of the presentation. However, we will have a question and answer portion at the end where we encourage you to type your questions in for our presenter. Thank you once again and for helping us recognize Women's Health Month. Today, we're going to be focused on an important and often under-discussed stage of women's health, menopause. It's an opportunity to learn more about the physical, emotional, and lifestyle changes that can come with menopause while exploring ways to manage symptoms, support overall wellness, and improve quality of life. Through our open conversation, through our education pieces, and our shared experiences, we hope to empower women with the knowledge and resources to navigate this transition with confidence. And to help us, we are today joined by Dr. Valerie Allen. She is a board certified OB/GYN at Endeavor Health. She attended the University of Toledo College of Medicine and completed her residency in OB/GYN at Rush University in 2017. She's a Menopause Society certified practitioner and has held her menopause certification since 2019. She cares for OB/GYN patients across all life stages and especially enjoys helping patients navigate the difficulties that may arise with the menopause transition. Thank you, Dr. Allen, for joining us today, and I'll pass it on over to you.
Great. So thank you for inviting me and having here today. It's an important topic. So the menopause transition encompasses the time before and after our final menstrual period. Always just like to start with some conflict of interest disclosure, which is that I have no conflicts of interest, and that starting with the symptoms. So frequently I have patients coming into my office, and this is the whole list of symptoms that they'll give to me. I don't feel like myself. And when we dig into it deeper, hot flashes, day or night, which, sometimes more like temperature dysregulations, poor sleep, fatigue, weight gain, muscle loss, irritability, mood disturbances, hair loss, low libido, joint aches, brain fog, and abnormal menstrual cycle. So the list gets pretty long and it starts to feel overwhelming for people. So starting with the definitions of menopause, just to have a frame of what is going on at this time and how to sort of define for your doctor what's happening, is the final menstrual period can only be known looking backwards, or what we say in retrospect, times 12 months. So you have a final menstrual period and then you go 365 days without bleeding. And that's the only way to know that you finally entered menopause. So natural menopause is permanent cessation of the menstrual cycle because the ovarian function is gone, meaning all the eggs have been used up. And that's happened now 12 months after the final menstrual cycle. And then the average age is around 51 to 52, sort of with a range of 48 to 58. We define early menopause or premature menopause as being before the age of 40 and early menopause being before the age of 45. So these groups have different symptoms and risk factors that come up for them. So when you're going through the menopause transition, though, it's the time leading up to that final menstrual period. And the menopause transition starts to happen when we notice more than 7 days of variance. So people tell me I've always been a 28-day kind of gal, and now I'm 21 days or sometimes 35. And so that time lasts until your final menstrual period. And then perimenopause is from that time until 12 months after the final menstrual period. So really, we end up using those two things interchangeably, and they just have a slightly different definition. Postmenopause then is the stage of life after menopause and has its own sort of different symptoms. So menopause definitions here too, I'd always like to make sure I clarify the difference between hormone replacement therapy and hormone therapy. So hormone replacement therapy we use to describe the highest doses of medications that we're using in someone, for example, who's lost their ovaries at the age of 40 and needs to be totally replaced back to their normal levels for that decade in an effort to reduce medical risks. As opposed to menopause hormone therapy, you don't need to be replaced. You have hormones. And you're going through the natural physiologic process, but we're using those hormones to treat symptoms of perimenopause and postmenopause. So in the physiology of things, what is happening? You have the normal menstrual cycle that I'm going to talk about, and then I'll show you postmenopause and the menopause transition. So I'm normally drawing this picture out for my patients in the office. So I tried to come up with an animation here then of the process as it's happening, sort of describe people. So here you have your uterus and the vagina, fallopian tubes and ovaries, the ovaries here, and your brain are the main components of these things. So you're born with all of the eggs that you're going to have when you're at birth, and it's an abundance of eggs. Those eggs actually produce the estradiol. So your ovary talks to your brain and says, hey, I have enough estradiol. It's abundant. You should be able to ovulate. And so your brain then shouts down to your ovary and says, hey, sweet, go ahead and release an egg into the fallopian tube. And that usually happens about mid-cycle. When you do, you create this pocket of hormone called progesterone that lives for about 14 days. When you don't get pregnant, that pocket of hormone dies, that level falls, and that's actually what tells the inside lining of your uterus to shed and have a menstrual cycle. So the hormones end up being this even ebb and flow that sort of go up and down, dependent on those hormones being abundant. Now, menopause is when you get to the point where you have no eggs that are left. And as a result, the estradiol is super low and your brain senses that and is real angry about it. So it's yelling at your ovary to do something. And your ovary says, I got nothing. So this level of hormones for the estradiol then is just flat and even and not fluctuating. So the problem is this transition point. So you have this decreasing, diminishing number of eggs. And the brain senses that it's not getting the same amount of estradiol as it did when you were in your reproductive years. And so it gets angry still and is yelling at your ovary, but this time your ovary can yell back. So your ovary may say, I don't want to ovulate. I'm just going to ovulate a little. And then sometimes the ovary gets really cranky and says, yeah, fine, I'll ovulate, and sends this really big signal. And as a result, this is where the chaos part sort of comes in. Instead of these even flows, we have just this chaotic, really unpredictable flow of hormones. And as a result, the innocent bystanders in this situation, or your uterus, ends up not knowing whether we're supposed to be having a period. Are we not supposed to be having a period? Is it heavy? Is it not heavy? And your brain also has innocent bystander with the different neurotransmitter chemicals that are there are also deeply impacted by all of this happening. The other point I like to make with this picture is that when we come in and talk about, can you check my hormones? If you were going to check a hormone on one day, you can see, in any of these different situations, it might be a different level. Or on, for example, this day, it might be that you don't know which curve you're on, essentially. So checking the hormones ends up being difficult because it doesn't tell us what's going on day to day. It just gives a snapshot in time. So we don't know where it was or where it's going, or if it's high or if it's low, and it makes it not as helpful to check those hormones, in which case. So I need my hormones checked. Not usually. There's really specific circumstances we'll do it, but in general, going through perimenopause, we can tell based on your hormonal fluctuations with your cycles, as opposed to needing labs to have that checked. I always say that's similar to puberty. You wouldn't be 16 and starting to have your menstrual cycle and say, "Hey doc, am I in puberty?" You get the answer in puberty. But people come in and say, I want my hormones checked. And that's usually because something feels off. And so the goal of perimenopause, I believe, is to be able to live your best quality of life in the most healthy way. And so that's ultimately more important than sort of checking these hormones, as it were. So then the next question comes up, can hormonal medication then alleviate all the chaos and help these symptoms? And the answer is sometimes. And there's actually two different types of hormonal therapies that we'll use for people. Birth control pills are actually a combination of hormones as well as the hormone therapy. So talking about these two hormones that come in each of these sets, estrogens and progestogens. Best friends forever, as they say. If you have a uterus, you always have to have, with the estrogen is what's usually going to be the treatment for your symptoms, and that's going to tell the inside of your uterus to grow, which can risk some cancer cells, and the progestogens actually stabilize that growth to make it so that risk is low. In other words, unopposed estrogen, just giving estrogen alone, carries the risk of uterine cancer unless you don't have a uterus, and in which case the progestogens don't need to be there. But they should otherwise always go together for that protection. So with birth control pills, most birth control pills, or the standard ones that you think of when we say it, are coming with two different types of hormones. There's a synthetic estrogen and there's a synthetic progestogen. And that's important because these are usually very strong. They're very potent because they're meant to prevent pregnancy. So they're designed to be that strong. And there's different formulations that exist with different doses of this synthetic estrogen, as well as what we call different generations of these progestins, each of these having different side effects and pros and cons. So there's a lot of ways we can tweak a birth control pill, for example, to try to alleviate for side effects. So here's my fun drawing again. And the idea here is that birth control pills end up actually being the only thing that I have in my tool basket to be strong enough to cut off this conversation between the brain and the ovary and make it so they're just not talking to each other. And what that does is it takes this premenopause level of hormones and makes it flat and not fluctuating. The idea there is that we're eliminating the chaos for a person. It's not taking your natural hormones, though, and making it flat. It's taking that synthetic estrogen and actually completely suppressing the estrogen in your ovary, which means that it's taken over by these synthetic hormones, which can make a person feel stable, but as I said before, sometimes have bothersome side effects for people. The other hormone therapy is also sort of a mix and match of these two hormones. So estrogen therapy, most commonly these days, we're prescribing what's called bioidentical estradiol because we figured out a way to give that in a medication form, whether it be patch or pill. Conjugated equine estrogens, fascinating history, was used in the Women's Health Initiative. It was the only way they had to give people estrogens back in the day. I sort of digress sometimes because I think it's fascinating, is that they actually harvested from the urine of pregnant horses. So it's something like 14 to 16 different types of estrogens that are not naturally found in the human body. We've moved away from that over time. So the different formulations that exist, oral, transdermal, and vaginal ring, and these are all FDA approved to treat hot flashes. So what does hormone therapy do? It does not block ovulation, and it actually, in my mind, brings the basement level up and sort of cushions the flux. So if you think about it, the perimenopause issue is that it's not this even ebb and flow. Instead, it's this more of a crash or sort of an abrupt rise that happens. So it's this sort of change between high and low that can be an issue for people. As such, when we give hormone therapy, we're actually sort of bringing this basement level up, as it were, and so that flux doesn't have to be so great, which makes it so that the hormones and the symptoms that come as a result of it are still are alleviated slightly. And the reason that I think it's important to show it this way is because we're not blocking what's going on then with your hormones. We're only sort of cushioning it, which means that the menstrual cycle is still going to be a little bit chaotic. And part of the reason why it gets a little tricky with before the final menstrual period and giving these types of hormones, because we don't want to make your period worse in the meantime. So the other component of the hormone therapy are these progestogens, and the bioidentical progesterone is usually what we're reaching for in menopause. It's not a good treatment for bleeding. It's not a birth control, but it does help protect the uterus, and it does make person a little sleepy. So that's usually really helpful for the symptoms that people are having. In addition, the progestins are these synthetic progestogens that we can use, and these a lot of times are contraceptive or abnormal bleeding management. So you have the birth control pills that only have progestin in it, may be known to people as the mini pill. There's another version of it that's come out called Slin, which is a little bit stronger these days. You can have a Mirena or Liletta uterine implant in place to protect your uterus, give you birth control, and control your bleeding. Usually it's an 80% blood loss reduction with one of those devices. And then something even stronger like norethindrone acetate, which is not approved for contraception, but is pretty good at controlling bleeding. The implant that goes in your arm is good contraception, but doesn't control bleeding. So a lot of times we're figuring out for patients what exactly they need and what are the pros and cons, and sort of coming up with these combinations for them. And then some hormone therapy actually already has them sort of combined within each other. A couple of the pills and patches have that, and that's kind of convenient as well. The next question is always, but is it safe? And the answer is usually, and it usually depends on the individual. So that's the other thing a doctor should take into consideration if they're prescribing hormone therapy for a person. The biggest thing we've taken away over time is age of initiation. So the common wisdom in our specialty now over years of looking at this nuance is that starting hormone therapy before the age of 60 or less than 10 years after your final menstrual period ends up being a lot safer than starting it after that time, probably because you develop risk of cardiovascular disease as you age, and then throwing estrogen on the top of that is what risks things like stroke and heart attack. Whereas before that time frame, actually, there's some evidence that there may be slight reductions, which is reassuring. Other medical problems, if you have a history of blood clots or pulmonary embolism, these estrogens can increase the risk of that happening again. For your cardiovascular risk, we look at something called an ASCVD score, which takes into account things like diabetes and blood pressure and other health factors that might make you more at risk for heart disease, and sort of plugs out a percentage risk. And from that, we can tell whether you're going to be a good candidate for hormone therapy. Also, obviously taking into account personal history of breast cancer and family history of breast cancer as well. And a lot of these things are not an absolute reason not to give somebody hormone therapy, but they're things that we take into consideration when we're figuring dose and route. The other question I get is, should I take it for chronic disease prevention? And it's really not recommended for it at this time. I really wish it was. It'd be sweet if it was. There's some evidence that maybe it helps prevent things like dementia and heart attacks, but the evidence is so sparse and all over the place that it's been hard for us to say, like, for sure this person will benefit. And so it's really hard to across the board tell people to take it for that reason if they're small. So we need more research. The only exception for the chronic disease prevention here is osteoporosis prevention or bone density protection. And I'll mention that a little bit later as well. The other plug I like to put in here is just to be wary. Anytime somebody's trying to sell you a product, there's so many books and podcasts and guest lecturers out there. But the idea is that sometimes people are trying to make a buck off you, and that's cool. People need to make a living. But I always like to tell people to be wary and just think of things in the context of not being taken advantage of with these things that are claimed to be a cure-all. A lot of times they can cherry pick these studies and not look at the big picture and take things out of context and make things sound really amazing. So the bottom line is organizations like the Menopause Society exist to give us this context, and it's great that we have more therapeutic options, but hormone therapy can't fix everything. So we always have to think of the big picture as well. At the end of the presentation will be the website for the Menopause Society, just to have that reference as sort of a leap off point for a lot of these different things that I'm going to talk about. So what about all the symptoms though? Doc, I don't feel good. Okay, so what do we do? You got these treatments. What are we going to do? So going through each of these hot flashes, the gold standard, if you come to me and you're not sleeping well because you're having hot flashes or you're miserable during the day because you're having hot flashes, hormone therapy, gold standard. Truly, I give people even this in smaller doses and their hot flashes are gone and they feel so much better. It's kind of like magic. It's one of the biggest things I do to feel like a magician sometimes. And there's other side effects, like we said, that we have to work out, but it's usually pretty quick that we can take care of the hot flashes. If for some reason you can't take the hormone therapy, most of the time they're not FDA approved for this reason, but we go through gabapentin, for example, a nerve pain medication at night for helping with sleep and hot flashes. Mood medications tend to stabilize mood in addition to decreasing hot flashes. And then we have some really sweet new drugs on the market, which are called neurokinin receptor antagonists. They actually work at the level of the brain that's above where estradiol works, that actually reduces the hot flashes as well. So that's pretty cool technology. So sleep disturbance. And I is the hammer this point home with the presentation, but sleep disturbance and poor sleep is really sort of the key to everything as you go through the menopause transition. So if you're not sleeping well and you're not getting restorative sleep because of your night sweats, we got to fix your night sweats. We just got to start there. Is that the only thing that's probably affecting your sleep? It might not be. You have to think of the big picture there too. Having good sleep hygiene, considering an obstructive sleep apnea evaluation, which can present differently in women compared to men. Sometimes more of a softer snoring noise as opposed to these big sort of noises that men may have when they're having these brief episodes of not breathing in the middle of the night. Treatment of anxiety and depression symptoms. You can imagine if your brain is spinning out on anxiety symptoms, PTSD symptoms, it's going to be hard to sleep. You can consider things like cognitive behavioral therapy for sleep. It's actually one of the most well-studied and most effective ways to help with sleep, but obviously takes a little bit of work, so that's tough. Consideration of reduction of substance use, for example, alcohol. Treatment of pain. If you're in pain, it's hard to sleep. And then other labs, it may be helpful to look into thyroid. If your thyroid is high, it can make it hard to sleep. And your iron stores, restless legs can also contribute to poor sleep as well. So that's going to be part of the point here, is just making sure we're getting that's that base layer, making sure people are feeling better through this transition. So what about fatigue? Again, if you're not sleeping well, then you're probably tired. So we got to fix your sleep and we got to fix your night sweat. So we start there. And then we work on the sleep disturbances, but fatigue in general also checking thyroid. Your thyroid's low can cause you to be fatigued. Ferritin's this more sensitive measure of your iron stores. So somebody can look like they're not anemic, but actually have really low iron stores. Usually we want it to be around 60. And most women, when I check it in the menopause transition, because of their heavy periods, will have it in like at 5. And that makes a person feel so tired. So it's this low hanging fruit that we can do to help maybe alleviate menstrual cycle issues, for example, but then also replace iron and help that fatigue. And then consider what other medications may be adding to fatigue. Some blood pressure medications, for example, can contribute. And consider mood diagnoses. Depression, anxiety, PTSD, which I'll get to, can heavily contribute to fatigue, as fatigue is actually part of the diagnostic criteria for some of these things, meaning it's how we tell if people have the, depression or anxiety. Weight gain, muscle loss. Again, if you're tired and you can't sleep, and so you don't want to exercise the next day and you have the energy to make yourself these meals that may be a little bit more healthy, then of course it's going to be hard to lose weight or prevent weight gain. So you got to have the energy to be able to move during the day. Exercise remains key, including resistance training. It ends up being super boring. It's like, oh, she's going to tell us something new and exciting, but really there's not. The GLP-1s, of course, are this new landscape, which are really groundbreaking, but we're really only starting to learn how that fits into the long-term health picture for menopause. So it's not a cure-all quite yet either. And so exercise and sleep, again, super boring, but really important for this transition. And I always like to make a note that this topic's really complex and comes with really heavy historical cultural influences, and is also an area where people try to make big bucks. So just to reassure you, there's no secret you're missing out on. Really just trying to make sure that we're maintaining muscle mass by doing weight training and trying to eat a healthy, well-balanced diet and move your body. It's sort of nothing groundbreaking there. Irritability and mood disturbances. Again, if you aren't sleeping, then you're probably really cranky. So we got to fix your height in the hot night sweats and ensure you have adequate sleep. But then there's other mood diagnoses. And a lot of the symptoms of depression and anxiety actually really overlap with what we label as perimenopause. And as I was mentioning before with that picture, there's a lot of evidence that the serotonin and the dopamine may actually be really heavily influenced by that severe fluctuation of estradiol, especially for people who we consider to have more vulnerable time periods in their life. For example, if you're someone who's had really bad PMS, or the more severe version we call premenstrual dysphoric disorder, or PMDD, if you've had postpartum depression, if you have a history of depression or anxiety, all of these make it so that this is this vulnerable decade that crop back up for you. And it may not be cropped up forever, but it's good to recognize that it may be something to treat in the meantime. So then I like to point out what are the diagnostic symptoms for these things, because you read through this list for depressions and it's literally that list I gave you for perimenopause, right? So it's depressed mood, appetite, weight changes, sleep disturbances, restlessness, being slowed down, fatigue, feelings of worthlessness and guilt, cognitive decline, things like brain fog. And then a suicidal ideation obviously is one that we really want to make sure we evaluate for patients. Super important to make sure we keep people safe. And then anxiety symptoms, a lot of these things, the restlessness, fatigue, difficulty concentrating, irritability, sleep disturbances. So we're really trying to make sure we're not treating one thing without leaving another thing untreated, because the first line for those diagnosed with formal mood disorders, of course, is mood medications. That being said, there is some promising evidence that the estrogen-based therapies, specifically transdermal estrogen, meaning it's a patch on your skin, have really good antidepressant effects, and can be used with women with major depression or with or without hot flashes. And we don't see those same benefits, though, for women in menopause. That being said, we still consider the mood medications first line, but a lot of times they work really well together. And so, again, it's a matter of a conversation with your doc about what your goals are and what resistances you have to certain medications, and helping to pick the right thing for you. Hair loss, I hear this all the time. Hormone therapy doesn't help that. Maybe it's associated with perimenopause, not consistently so. Again, we're checking thyroid and the iron stores again and again. And if you're really having trouble and struggling, there's definitely some things the dermatologist can help out with, because first you should be looking to make sure we're not missing a secondary cause. Low libido. This is always included on that list. I'd say like 9 times out of 10. This is a really complex topic. So I don't actually have the ability to sort of go through the entirety of low libido today, since it's such a complex topic. But broader topics to consider within this are that a lot of times people start to have pain with sex during this time, with vaginal intercourse specifically, and then are not able to have enjoyable sex as a result of that. There's relationship and communication with issues with partners about sex. So, for example, one person may have more desire and the other person may have less, and sort of leveling that out to make sure that both people are communicating well about it. It's not becoming resentful. Stress heavily contributes to libido, which again sounds super boring, like, sweet Dr. Ellen, I'll just reduce my stress levels. Like, that's no problem. But truly, they do these research studies where they have the amount of brain flow in the brain, and the women who are thinking about these stressful thoughts and having that part of their brain activated are the ones who are not really able to be present and enjoy the intimacy that's happening, whereas women who can shut that off are a lot more likely to enjoy it. So it speaks to the mindfulness aspects of this and things that can be helpful. There's also different physiologic responses for male and females, recognizing that women in general, and this comes straight from like the International Society for Women's Sexual Health that I attended, are far less likely to have spontaneous desire. So it ends up being more receptive, which means priming your brain to be open to the idea of it, which sounds like a subtle difference, but I think it really helps women to conceptualize that sometimes. So the one nugget that's usable that I'll leave you with today is that the pain with sex, there's really some really simple things that can be done about that. So first of all, it's just making sure you have the right lubricant. Again, 9 times out of 10, I have women come in and tell me they're still using a water-based lubricant. There's nothing wrong with it. It's just not optimized for the menopause transition. A lot of times it has glycerin in it, which is sensitive to sensitive skin. We're talking about products, for example, like Astroglide or KY jelly, compatible with condoms. So that's helpful for prevention of sexually transmitted diseases. But there's other things that can be used in place of water-based and still have that same protection. The biggest is the silicone-based category. These tend to be a little bit longer lasting, a bit more moisturizing, and are still compatible with things like condoms. Oil-based, also moisturizing, but will break down latex condoms. So it should be a situation. So we used to call the syndrome of the menopause transition and menopause vaginal atrophy or vaginal dryness, which are just terrible phrases, in my opinion. So we came up with something that is better, but it's kind of a mouthful: genitourinary syndrome of menopause, or GSM. And really what this means is that the vagina and the skin on the outside are sensitive to the estradiol fluctuations. So my key point for women is estradiol cream, if there's not a reason not to take it, and there's very few reasons not to take it, can be your best friend for both your vagina and the vestibule. And I like to show people where to apply it. So that's why I give you this warning. I'm about to show you just a drawing of the female bottom, just to give you some idea of where this should be applied. So we're talking about the vestibule, which is, you have your labia majora here, which are the larger, usually hair-bearing lips, and then the labia minora on the inside, which are the non-hair-bearing lips. And then you have what's called the vestibule, which is the surface that leads into the entrance of the vagina here. So what I find most of the time is it's actually sort of like this diamond shape area that it's really sensitive for people, including where their urine comes out, and then the actually the lower 1/3 of the vagina instead of all the way at the top of it. So applying the estradiol here sometimes gets forgotten when we prescribe that for people, because it comes with an applicator that can get plungered all the way to the top, and then sort of glops out and is annoying to people. But making sure that you target this area here specifically in the lower 1/3 of the vagina can be really helpful. And I like to show this picture over here because this is actually what the surface skin looks like when you have a lack of estrogen. And so you have these cells on top that have no strength or integrity. And so when friction happens, these are easily rubbed away and cause redness and irritation and burning. And when you're using the estradiol cream on this surface, you're actually rebuilding these surface layers and making it so that the elasticity is better, the fragility is better, and that you're able to have more enjoyable intimacy, but also it fixes problems for people like it painful with wiping with toilet paper, for example. There's other medications that are available for libido. And so people always come to me and want to talk about testosterone therapy, which I do prescribe really in the right setting following this global consensus position statement here. There's two medications that are available for women before menopause, which is Vyleesi, which is an injection, and Natty, which is a daily pill. And both of those have some benefit for increasing satisfying sexual encounters, is what they were looking for. But they can be cost prohibitive and work perhaps better when we've figured out this base for libido that we've talked about, those other 4 tenets in the beginning. Testosterone therapy has a place only in menopause and only for women with hypoactive sexual desire disorder, which means women, we've really peeled back all the layers. You're not in pain. You're able to have enjoyable intimacy with your partner, yet and your good communication and all of these things we've sort of got a firm grasp on, but that's still not there. And so we'll use testosterone therapy. The problem is that in the United States, the testosterone therapy comes only in male formulations. And so we have to what's called microdose it, which means take 1/10 of a man's daily dose, which is a gel. So you have to measure out these like little tiny drops to rub on the tops of your legs, for example. And then it requires a lot of monitoring for us to make sure we're not giving you too much. Side effects can include permanent deepening of the voice, for example. A reason we don't give it before menopause is because you still have fluctuating levels of testosterone before then. And so giving you this on top of that would put you above what are called super physiologic levels, which is where we run into trouble with the side effects: acne, sort of male pattern balding, the deepening of the voice, and sometimes differences in cholesterol, for example. So testosterone therapy does have a place, and we do use it, but really it's sort of very specific category that we're prescribing it for people. This is the one where I most more likely see that people come to me and say, well, the influencers are saying it's going to give me energy, it's going to really give me this vibrance. And I really wish that were the case too. It's just not. It's not been shown in the bigger picture studies to be able to do that. So that's one of those where I caution people not to sort of get caught in that trap. Joint aches. This one can be really tough too. So it's actually experienced by about half of the women going through the menopause transition. A lot of times it's transient, but there's some other basic labs we can think about, same labs as we've talked about before. Also, sometimes some statin medications can cause muscle aches. That's the lipid or cholesterol lowering medications. And then thinking about other medical conditions, right? So thinking about things just outside of it being perimenopause. What else could be happening? And so that could be an autoimmune condition where your body's fighting itself, or infectious situation, or other injuries. And the problem is there's not really a great management solution here. Usually telling people to really touch base with their primary care as it sort of gets outside of the realm of gynecology for me, thinking about things like physical therapy and what can we do to make sure your bones and muscles are strong. But there is some evidence that hormone therapy might help. This one's an if. I have had people tell me that it gets better, and I've had people tell me it didn't get better when we start them on it. So sometimes it's worth a shot if it's something that's particularly bothering you, but a lot of times we're not giving it specifically just for this reason. Brain fog is also really common too, that people find really, really bothersome. And why wouldn't you? Normally you can come up with these words on the spot, and now you're feeling like your brain's not functioning at the same rate that it was before. So it does seem to be a common experience for women going through perimenopause, and it does appear to be temporary, and is usually defined by these memory and attention difficulties. But the key to remember here is dementia before age 64 is really rare. And the hot flashes may affect sleep and affect cognition and brain power. Again, sort of going back to let's fix your sleep, let's fix your night sweats. And some of these mood changes like depression, anxiety, we were talking about difficulty concentrating, and some other symptoms that go along with depression, anxiety can also contribute. So thinking about that in the big picture. But some of the brain fog is not explained by the above, which is really frustrating and an area of ongoing research to try to make better for people as well. So again, treat your night sweats, focus on sleep improvement, ensure adequate mental health, and then dementia risk reduction. So it's like, okay, my brain fog is not dementia, but I don't want dementia, Dr. Ellen. What can I do to prevent it? Which is a really reasonable question. And the answer ends up being scoring again. It's all the same things we've mentioned, but it's maintaining a healthy lifestyle, engaging in these moderate intensity activity, which they say, at least 150 minutes a week, combining with a Mediterranean diet, trying to maintain an appropriate body mass index if you can, avoiding smoking, excessive alcohol use, and head injuries, and following up with your primary care doctor. And I think this is really important for dementia, but also for heart health. Is heart disease ends up being actually the biggest killer of women that somehow gets sort of glossed over. And so making sure that you're following with your primary care doctor for that primary prevention, watching your blood pressure, watching your cholesterol, and looking for your risk of diabetes, and making sure all those things are treated. The other thing to do is to keep your brain active, engage in social activities, come to lunch and learn opportunities to learn more information, increase cognitive reserve by learning new skills and engaging in challenging tasks. The other thing to mention in here is most of the time during the menopause transition, women are having some issues with their menstrual cycle. And so if it's particularly heavy or close together, or happening too long, more than 7 to 10 days, for example, then usually we're pretty quick to start a workup with labs and an ultrasound. So the biggest thing to keep in mind here is that your doctor will have on their mind to make sure that there's not a risk of uterine or endometrial cancer. So that inside lining of the uterus, where that was what sheds during your menstrual cycle, can actually get a precancer, a cancer, and it ends up being the number 4 most common cancer for women in the United States. The good thing about it, if there's a good thing about cancer, is that it can be found early and treated early. So it's normally found in early stage, which means that usually that you are being really aggressive about looking for it. Usually you can do a biopsy in the office, a really small biopsy, or a provider may recommend something like a dilation and curettage, or DNC, as a way to obtain tissue from the inside of your uterus to make sure that it's not cancer. The ultrasound also makes sure it's not something like a polyp, which is a skin tag that can be in your uterus and can be easily removed in the operating room with a camera and just a little suction device. And there's bigger things that we can't solve with some of these medications we've talked about, or these minor surgeries. And of course, hysterectomy ends up being sort of the final part of that. And further discussion, I would say, is sort of beyond the scope of this talk. I could give you a whole talk on how to treat menstrual problems as an aside. So that's sort of the thing to focus in on the perimenopause transition. And then here's the takeaway that I like people to take from this lecture, is that breast cancer is the most common cancer in women. Really get your mammograms, ladies. There's a lot of different recommendations out there for when you should start and how frequently you should get it. U.S. Preventive Task Force, for example, sort of throws in like every 2 years, sometimes starting at age 50. I think they changed it recently, but the bigger societies like American College of Gynecologists and breast cancer surgeons and American Cancer Society really recommend starting at 40 and continuing that yearly, and maybe even earlier if indicated by family history or risk. The bottom line is 1 in 8 women will get breast cancer. That's 12% if you live to be 80, and that's your baseline risk. So that's without taking into account other lifestyle factors that may increase your risk. They quote that 3 alcoholic beverages per week increases it sort of just as much as hormone therapy increases it, for example. So the alcohol ends up being a part of it again, as well as family history as well. And the other bottom line is that breast cancer is easily curable if you find it early. 95% of women who have breast cancer diagnosed will have it be able to be curable, but that's really because we've become very good at finding it early and taking care of it. So the other thing to consider is you have family history, seeking out genetic consultation to see if you qualify for enhanced screening, which usually means that you can go every 6 months and rotate between a mammogram and a breast MRI. And the idea there is that if you're at a lifetime risk of 20% or more, so 1 in 5, then you may even more benefit from early detection, looking more frequently. So get your mammograms, and if you get breast cancer, it's easily cured. It shouldn't ruin your life. Other thing that we think about is colon cancer screening actually starts at age 45 or sometimes earlier for people. This is a change from 50, which was used to be the old recommendation. So that falls squarely within this menopause transition period where really should be looking out for colon cancer as well. And then osteoporosis prevention. So these guidelines end up being kind of confusing for doctors and also then for patients. Currently, it's recommended that we start at age 65 or earlier if you have an elevated what's called FRAX list. And I included the link there. It's the little quiz that you can take to see what if your baseline risk exceeds that of a 65-year-old. And we use a bone density scan to screen for it called a DEXA scan. One of the easier things we put women through, you just have to lay there and it takes an x-ray of the density of your lower spine and your hip and your upper leg. And then the vitamin D supplementation there sort of at baseline is recommended to be about 600 to 800 international units. And usually these higher levels, the 1,000 to 2,000 are only if you're deficient or even higher if guided by your primary care doctor. Adequate calcium intake, making sure you get 1,200 milligrams a day. How do I know if I'm getting 1,200 milligrams a day, Dr. Allen? Usually we're recommending dividing that out between 3 meals to have better absorption. So it's about 400 a meal. And from there, you end up choosing things that may have dairy components. You can look up on the internet and see what kind of things can contain these calcium, but it's really better to get it in your diet. Weight-bearing exercises, again, weight training, resistance training, cardiovascular or cardio exercise as well. And hormone therapy can prevent osteoporosis by stabilizing bone density. What's interesting, though, and the reason it ends up being confusing is we don't recommend hormone therapy for everybody for this indication. And sometimes I get the argument from people that getting the scan at 65 may be too late. So there's not an official sort of guideline quite yet, but it's sort of tilting in the direction of maybe having us look earlier just to allow for more primary prevention. Since you want to be able to prevent having a fracture from something silly like tripping on a crack or falling from like a standing height. It really sort of ends up ruining the quality of life for people. So what supplements do you recommend, Dr. Allen? I don't. And that's my bias. I always tell people is certainly there's so many supplements out there and the supplement industry ends up being multi-billion-dollar industry as well. So really only the targeted ones, like I mentioned, like vitamin D3. In fact, the Menopause Society no longer recommends supplements for the treatment of hot flashes because there's really no data or evidence that it works. And there is some potential for risk with the different supplements are not usually overseen by any purity agency, and so it may have contamination that can lead to liver injury. So it's more risk than benefit a lot of the times. And the other thing to think about with supplements is that if you are checking your iron and you need iron replacement, then hopefully we're only giving you iron for a short period of time, for example. A lot of these things are meant to be sort of ways to rebuild up certain levels as opposed to being things that are going to be a cure-all. Parting thoughts. There are many reasons a person might not feel well in their 30s to 60s, including perimenopause and postmenopause. So I really encourage people to seek out a provider who's able to look at the whole picture. You can use the Menopause Society website to actually find a certified provider and seek out someone who's willing to consider hormone therapy for the right indication. Be wary of any providers who claim one thing can fix everything. And sleep and exercise over and over again are really what's associated with prevention of chronic disease. I get it, it's boring, but it's super important. And our job as doctors should be able to help you sort of achieve those things in the best way possible. Thank you.
Awesome. Thanks, Dr. Allen. It's a lot of good information. I know I learned a lot. Is there, if we have any, pardon me, let me start over. If we have any comments or questions for Dr. Allen, we can go ahead and put them in the chat now. We just have a couple minutes for some questions and answers for you guys. But yeah, I mean, Dr. Allen, I appreciate all this information. I know my, you know, as somebody who is married, it's always good information to have just,
Yeah.
And just know for day-to-day life. Like, I feel like anytime we learn anything, it's always good to have in our back pocket just for answering questions. And especially, I believe that we are all health educators. So if we're able to help anybody with this information, I think that that is ultimately the end goal, right?
100%.
So if go ahead and, like I said, type your questions in the chat or any comments for Dr. Allen. I want to just say that if anybody has any questions or need any support from wellness, you can go ahead and reach out to us, wellness@transitchicago.com. As always, you guys will get a recording of this, so be on the lookout. So if questions don't necessarily come up now, please feel free to reach out to myself and we can get them over to Dr. Allen too. And Patrice says, thank you for the very useful information. Thank you so much for sharing with us today. It looks like we don't necessarily have any other questions. So, Dr. Allen, I want to once again thank you for your time and thank you to everybody who joined us today. Thank you for being engaged and thank you for taking the time to learn about something that either you wanted more information on or just something that you wanted to learn more about. So I appreciate it.
Yeah, happy to bring this information to people. Thank you for inviting me.
Yeah, of course. Well, you guys have a wonderful rest of your day. Happy Friday and have a wonderful and safe weekend.
Thank you. Take care.
Take care, everyone.